Good morning. Welcome to chapter 35. We're going to be talking about obstetrics and neonatal care. Try to get through this chapter smoothly. I am by no means an expert on this. Obviously, we're going to be talking about obstetrics. We're going to be talking about some of the pathophys, again, assessing of a pregnant patient. Talk about some normal delivery stuff, abnormal deliveries, and then third trimester issues, ectopic, so some other emergencies, and then assessing and taking care of newborns, neonatal resuscitation, and talk about trauma. So with trauma we're going to apply fundamental knowledge to provide the basic and selected advanced emergency care and transport based on assessment findings for an acute injured patient. There's going to be some special considerations. All right. So most births require little or no medical intervention beyond basic interventions, such as suctioning, drying, and simply just warming the baby. Others may be life-threatening to both the woman and the baby. Arriving on scene of a woman in labor can cause anxiety and fear on both the EMTs and, of course, the expecting mothers. If labor progresses quickly or other factors intervene, you may have to deliver the newborn in the field. So here's my outlook on field delivery. I have never had a field delivery. I've had 2 calls this last year where it was the closest that I've been to a field delivery. One was somewhat imminent. She was actually having close contractions. There was no presentation yet, but it was set up as a home delivery. We've been on, I'm sure most of us have been on several of these type of calls where the medulla or whoever is helping with that home delivery, something happens, there's a concern, and then 911 is called. Usually that's obviously an area of concern for us because all the things that the doctors and the nurses have at the hospital are not readily available with these home deliveries. Should something go wrong, we have 2 patients, obviously, or potentially more if there's, say, twins or triplets, whatever. But my outlook with the field delivery, it's truly I would love to be part of. I've been there for my children's birth. Most people, I guess, don't really want to be involved in a field delivery. It's considered gross by a lot of people. It can be messy. It can be a little scary because should something go wrong, it's craziness that you have to take care of. But in the field that we're in, we see so much carnage, so much death, that honestly, it is a breath of fresh air to think about watching new life come in. We see it go. We watch people die in front of us at times, but then to have that opportunity to actually see life come into this world, to me, honestly, is a huge motivating factor. Why I look forward to having my first field delivery. So there's my outlook. So if labor progresses quickly with or other factors intervene, you may have to deliver the newborn in the field. So usually requires little help from the healthcare provider. With these, nature takes care of itself sometimes. We typically don't have to do a whole lot on these. For those who have delivered in the field, it's more or less just kind of coaching, getting things prepped, and then catching. And just be prepared to catch the baby, and the woman, the patient, she's going to be doing most of the work for you. So anatomy and physiology review. Female reproductive system includes this ovaries, fallopian tubes, uterus, cervix, vagina, and breast. So that's the complete female reproductive system. Pregnancy most frequently occurs during a certain time of the menstrual cycle after an ovum is mature. So if the fertilization does not occur, the lining of the uterus sheds during menstruation. So that's, most of us pretty much understand how that works. Females, the external genitalia include the vulva, labia minor, clitoris, prepuce, labia majora, and the mons pubis. So those are some of the external genitalia that the book talks about. Gestation is the process of fetal development following fertilization of an egg. So fertilization occurs usually in the distal third of the fallopian tubes. Fertilization egg, the zygote, moves through the fallopian tube toward the uterus. From time to time, the fertilization to the end of the 9th week, the developing embryoblast, part of the blastocyst, is referred to as an embryo. So all those technical terms. Here's a picture from the 10th week and beyond is referred to, so it would be referred to as a fetus. The umbilical cord connects the placenta to the fetus via the fetal umbilicus. During labor, when the fetus descends into the birth canal, the pressure on the amniotic sac causes its rupture. Amniotic sac is the membranous bag that fills with amniotic fluid to protect and cushion the developing fetus. So that's the technical term for that. And during labor, the pressure on amniotic sac causes this rupture. Yeah, we talked about that. I just said that. And the gestation period is the time it takes when the infant to develop in utero. 40 weeks of pregnancy form the prenatal period, divided into 3 trimesters, and we're pretty. I'm sure most of us understand that as well. And then the fetal heart tones are audible with a fetoscope at weeks 17 through 20. Female and male genitalia may be distinguished by ultrasonography at week 18. A newborn is a recently born baby for the first few hours of its life. During the first 28 days of life, a baby is considered a neonate. And then between the ages of 1 month and 1 year, it's referred to as a baby, or the baby is referred to as an infant. So this slide would be good to understand and try to remember as far as the description for neonates. Again, it's the first 28 days of life, and then that's 1 month to 1 year, it's considered an infant. So normal maternal changes of pregnancy. During the pregnancy, many other body systems undergo changes to support the growing fetus. So it's that mother can go through significant changes. Total blood volume increases about 50%. By about 50%, increase by 50% by 40 weeks, and the red blood cells increase in number by about 30%. Output increases by 30% to 50%. And in the 2nd and 3rd trimesters of pregnancy, the gravid uterus may compress the woman's inferior vena cava when she lies supine. So this is when we get those, they can go have a poor circulation, and why we also need to consider putting them on their left side, say during transport. There's an increase in red blood cells. It heightens the pregnant woman's need for iron. Respiratory minute volume of the patient increases by about 40% by full term. There's a decreased GI function, could affect the absorption of medications that we may have to administer, so something to take in consideration. And pregnant women often have edema in their lower extremities. Many complications can occur during the pregnancy that obviously can threaten the health and life of both the woman and the fetus. Vaginal bleeding is common in early pregnancy emergencies. Most spontaneous abortions occur during the first trimester. An elective abortion is brought about intentionally. So you need to be says be dispassionate and professional regardless of your personal convictions when it comes to abortion. Okay. Obviously, and that's something that is kind of big in the news right now and is making everybody go cuckoo, cuckoo. So a threatening abortion is an abortion that is impending or potentially can occur. So it's characterized by vaginal bleeding during the first half of pregnancy, can progress to miscarriage or abortion, or it just may subside. Treatment is usually complete bed rest for that patient. So they're going to be potentially on bed rest. An imminent abortion is impending and threatened spontaneous abortion that cannot be prevented. So we have several different terms when it comes to the abortion. So we have, again, the elective. We have impending or potential, which is when they're going to be put on bed rest. And imminent, we're now on imminent abortion. So you maintain blood pressure and prevent hypovolemia is important. Treatment consists of administering the 250 milliliter boluses of normal saline. So again, administering the saline, we get to that, you need to reassess vitals, see where they're at with blood pressure, heart rate, 100% supplemental oxygen via non-rebreather mask at 15 liters is considered important. And then you want to provide emotional support because this patient is going to be going through a lot of stress and you need to try to calm them down. Obviously, that added stress is not going to be helpful on her. It's going to be it's actually going to be making things worse. An incomplete abortion occurs when part of the products of conception are expelled but remain in the uterus. So you're going to have vaginal bleeding. That's going to be present, and it will be continuous. It says, be alert for signs and symptoms of shock. So you're looking for that hypovolemia, symptoms of shock. You expect the blood pressure to be lower. So we want to treat accordingly with IV O2, trying to keep them warm. If products of conception are protruding from the vagina, consult medical control for instructions. So again, we're going to be getting on the horn, calling medical control for some little help over the phone, trying to give us some direction of what they want us to do. You know, and sometimes these patients are going to go straight into the ER. It's rare that this patient would go over to labor and delivery. So unlike imminent birth, where it seems like we're going straight over to labor and delivery. So this patient will probably go straight through the ER. Ectopic pregnancy, ectopic, is an implantation growth of the embryo outside of the uterus. So it's going to be implanting in the fallopian tube or on the ovary, in the abdominal cavity or peritoneum, or in the cervix. So it can be in multiple different places, and the term is ectopic pregnancy. So they're going to usually feel abdominal pain, cramping. It could be cramping, it could be stabbing. It's going to be, I've been on a few of these, and it's sudden. We found them in the bathroom. They've got bleeding going going on, their blood pressure is low, their heart rate is elevated, and they're just simply miserable. And it can be a life-threatening emergency. It's important to get this patient, recognize that this emergency, obviously by doing a good assessment, asking those important questions, and then getting them transferred to a gurney and off to the hospital rapidly. So let's see what else to say. The embryo will not survive with this and must be removed surgically in order to save the woman's life. Third trimester bleeding is any detachment of the ovum or embryo from the uterine wall, and that will result in bleeding. Yeah, vaginal bleeding is a serious sign of any stage at any stage of pregnancy. But complications increase as the gestation progresses. So in third trimester, bleeding presents the most dangerous hemorrhage in terms of risk to the health of the mother. Bleeding and the placenta. Major causes of substantial hemorrhage before delivery are abruptio placenta and placenta previa. So those are two different things. It's good to understand those as it talks about it in the book. Abrupto placenta is premature separation of the normally implanted placenta from the wall of the uterus. So it's actually separating. The patient's going to experience hypertension, or it could be as a result of hypertension, trauma, drug use, alcohol use, diabetes, or having multiple pregnancies. Patient will present with a sudden onset of severe abdominal pain, often radiating into the back. Let's see. There will also be decreased fetal movement and decreased fetal heart tone. So obviously this is an issue for the baby as well. If the hemorrhaging cannot be controlled after delivery, a hysterectomy may be necessary for this patient. Placenta previa is implanted low in the uterus and partially or fully obscures the cervical canal. So this is where it's preventing the baby from actually being getting into the birthing canal. Maternal age and multiparity can be some kind of those predisposed issues. Chief complaints include painless vaginal bleeding, so they may not have any pain with this, but they will be having some bleeding. And it's going to be bright red blood, obviously, from the vagina. Hypertension disorders. Chronic hypertension is defined as a blood pressure that is equal to or greater than 130/80 milligrams of mercury. So that would be good to understand for, as the book talks about. Diastolic pressures higher than 110 place that patient into an increased risk and category of obviously stroke and other cardiovascular dangers. Although you could have gestational hypertension, which develops into the 20th week of pregnancy, and it's occurring in women who have previously normal blood pressures. This is something that can resolve spontaneously in the postpartum period. It's not necessarily, obviously, like a chronic issue. Not going to. Hopefully, it won't last. Preeclampsia is an increase in blood pressure after the 20th week of gestation, accompanied by a protein release in the urine and often by edema. So this is where we need to understand in that 20th week, with that increase of blood pressure, preeclampsia, as it can be a concern, and how we treat that as it potentially leads into eclampsia. So symptoms include hypertension, severe headache, nausea and vomiting, agitation, rapid weight gain, and then visual disturbances. It can lead into eclampsia, which actually is when the patient has a seizure. It's because the pregnant woman had preeclampsia and there's no other cause for seizure, so that's how we would classify it as eclampsia. So supine hypotension syndrome may be an issue when a woman is injured and must be immobilized. So again, it's when that all that pressure is pushing down on the vena cava and causing some other hypotension, well, not just vena cava, but other vessels, causing other issues while they're supine. So let's see, a couple other things with this. Well, one other thing. So postpartum eclampsia actually can occur up to 4 weeks following the birth. So there's preeclampsia, eclampsia, and then postpartum eclampsia. And understand that postpartum occurs up to 4 weeks following the birth. All right. So Rh factor is a protein found in the red blood cells of most people. When a woman who is Rh negative becomes pregnant by a man with the Rh factor and the fetus inherits this factor, fetal blood can pass into the woman's circulation and produce maternal antibody, isoimmunization, to the factor. So it's normally not a factor in first pregnancies. In subsequent pregnancies, the antibody will aggressively cross the placenta barrier to attack the fetal red blood cells. The woman's body identifies these as foreign proteins, and this can result in the death for the fetus or cause hemolytic disease. And gestational diabetes is an inability to process carbohydrates during pregnancy. The patient may be asymptomatic or may exhibit the same signs observed in patients with diabetes mellitus. So they're going to have that polyuria, polydipsia, and polyphagia. So treatments consist of diet control, oral hypoglycemic medications. Patients with diabetes may experience wildly fluctuating blood sugar levels. Gestational diabetes predisposes the patient to hyperglycemia or hypoglycemia, one or the other. So it kind of predisposes. The fetus may grow to a larger than average size, and it may not be able to fit through the birth canal. So knowing this going into when that patient goes into labor could dictate whether it's kind of the severity of that labor. Is it going to be able to be vaginal, or is it going to be cesarean? And it could be not recognized until, say, the heart tones of that fetus start coming down slowly, because it's trying to be pushed out and it's not being able to. Hyperemesis gravidarum, a condition of persistent nausea and vomiting during pregnancy. I've known a couple people with this. It seems miserable. Prolonged vomiting results in dehydration and malnutrition. Suspected causes include increased hormone levels, some stress, and changes to the gastrointestinal system. Some of the pre-hospital treatments include administering oxygen, checking blood sugar levels, and providing IVs with saline support, and obviously transport to the hospital for continued care. Some of these patients, once they're, symptoms include severe and persistent vomiting in excess of 3 or 4 times daily. So, and you think about how sore your stomach is from, say, an episode of the flu and vomiting, and that's putting a lot of stress on that mother's abdomen, and then consequently that baby inside as well. Premature rupture of membranes, amniotic sac ruptures or opens more than an hour before labor. So if the pregnancy is not yet at term, there's a risk of infection for that patient, for the baby. Provide emotional support to the patient and then get them to the hospital rapidly. Any questions about that pathophys stuff? Perfect. All right. So, some special considerations that we need to have for trauma in pregnancy. The woman and her fetus are particularly vulnerable to trauma. Severe hemorrhaging may occur from injuries to the pregnant uterus. Anatomic changes during pregnancy have important implications for trauma. Relative redistribution of blood volume also occurs during pregnancy. The pregnant woman has an increased risk of falls. They're a little wobbly maybe. Aggressively treat a pregnant woman with a mechanism of injury that indicates shock is important, and substantial maternal bleeding will threaten the life of the fetus because that mother's blood is going to shunt and restrict those nutrients going to the baby. Assessment and treatment of the pregnant trauma patient can be kind of it shouldn't be much different, but there might be some other questions that we need to ask, obviously, that patient, as far as how far along is she, when was the last checkup, is she going in for checkup, is she taking prenatal vitamins, is this the first pregnancy, it's important to find, is there only one baby or is there multiple babies, twins, triplets, so on. A pregnant woman involved in a MVC, fall, assault, or other injury must be evaluated at the emergency department. So it's important that anytime this patient experiences some type of a trauma, they should be going to the ED for further evaluation, not just for that patient, but maybe more so for the fetus or for the fetus. Pre-hospital management of pregnant women with abdominal trauma is the same as for non-pregnant patients, though. We just do airway, breathing, circulation. Those are the highest priorities. And then, obviously, considering supplemental oxygen and IV fluids. Positioning is important. A pregnant woman should be transported to the hospital on her left side or with her right hip elevated about 6 inches. So if you were to keep her on her back, just kind of putting a pillow or folded up blankets underneath that right hip in order to kind of turn that, which will relieve some of that pressure off of the vessels. Some of the other field treatments, including opening the airway, administering the, like I said, oxygen, adequate ventilation, make sure they have adequate ventilation, circulation, IV fluids, and then transport. So, another big consideration that we need to take is understanding the cultural differences. So, different cultures may view pregnancy differently than you or I do in terms of social, psychological, emotional issues. How we talk to the patient, questions that we might ask. It's our responsibility to the patient and to the family to make sure that we respect those differences. Respect the differences, honor the requests of the patients. So not just, like I said, not just the mother, but also family involved. Teen pregnancy is can be another difficult one. Pregnant teenagers may or may not know that they are pregnant, or may be in denial about their pregnancy. Again, it could be an emotional, psychological thing where they're totally in denial because they know of what the repercussions are going to be from either family, friends, and they're trying to psychologically they might be a wreck. So they're trying to they're in denial. And they may be at that stage in denial where they just can't even really control that, and they just may not understand what's going on. Remember that pregnancy is a possibility, as you would for any woman of childbearing age. You need to respect that teenager's privacy and need for independence. If possible, perform your assessment and obtain the patient's history in a location away from her parents. This is a situation where it is probably pretty important for maybe 2 providers in the back of the ambulance, especially if they're in that denial or having some type of a psychological issue. It'd probably be good to have 2 providers for our safety during that transport. So assessing that patient. When childbirth is complicated by trauma or other conditions, any interventions that you provide the patient should benefit the fetus as well. Terms that are unique to pregnancy that allow you to more accurately communicate the patient's OB history with other healthcare providers. So some of these are going to be like gravida, which is the number of times a woman has been pregnant. And this is an area where I always get gravida and para mixed up. But gravida is the number of times a woman has been pregnant. Para is the number of times a pregnant woman has delivered a viable newborn. So you could have gravida 3, para 1. So they've been pregnant 3 times, but they only have 1 viable birth, which would mean they're currently pregnant now and they had a miscarriage prior. Prima gravida is a woman who is pregnant for the first time. Prima para is a woman who has had only 1 delivery. Multigravida is a woman who has been pregnant 2 or more times, irrespective of the outcome. And nullipara is a woman who has never delivered a viable newborn, although she has been pregnant before. So typically we don't use a lot of these terms other than gravida para. And this is something that, again, we need to make sure we get the numbers right, understanding that gravida is the number of pregnancies and para is the number of deliveries of viable newborns, because that's something that we need to communicate in our patch, possibly. Multipara is a woman who has delivered 2 or more viable newborns, and grand multipara is a woman who has delivered 5 or more viable newborns. Let's see. Okay. Primary survey is, we're going to continue to do the same thing we do for every patient. We need to obviously identify any gross hemorrhage, any immediate life threats, go into your ABCDEs and continue to manage those and other life threats that you come across. You need to take a moment to confirm whether the infant will be delivered in the next few minutes or whether you have time to continue to evaluate the situation. This entails you to potentially have to look. You're going to have to give it a quick look to see if there is any type of showing of that baby. Okay, see if it is crowning. Evaluate the trauma or other medical problems first, and then assess the effect of these problems on the fetus. Again, we have to take care of the mother before we take care of potential issues that can affect the fetus. If we take care of the issues that are affecting the mother, again, that is going to be helping us take care of the fetus as well. Okay. If delivery is imminent, you need to prepare to deliver at the scene. So make sure you have all your equipment ready and available. Make sure you're not just the equipment, but make sure that you're mentally prepared for this. Accept the fact that this is something that you may have to do in the field. That maybe on scene, in the house, or in the back of the ambulance. So it's not just the equipment, but our mental preparation for this as well. If the delivery is not imminent, we want to prepare the patient for transport and perform the remainder of the assessment en route to the ED. So make sure that you also have all the equipment necessary readily available. Have an extra set of hands. Get the pediatric bag down and have stuff readily available in case that baby is delivered en route. You have that equipment readily available. You don't have to go searching for it in the cabinet. If spinal mobilization is indicated, secure the woman to the backboard, kind of like they have here, and then you want to make sure that you're tilting that up again, kind of on that padding underneath that right side, and so that they can kind of relieve some of that pressure, and have them kind of roll to the left side there. Utilize blankets, rolls, towels, but don't forget that we need to treat that patient for potential shock. So we need to make sure that we at least cover that patient, keep them warm. Do a good history taking. Determine the patient's chief complaint if it's a nature of illness or the mechanism of injury. If you see a mechanism of injury, you need to find out what is wrong. Are they hurting? Where are they hurting? Are they having some just discomfort? Are they nauseous, headache? What's going on? Do a good OPQRST. Ask about the gravida and para. Ask about length of gestation. So where is she at? Which trimester? How many weeks? Most patients are going to know this. See what, try to find out what the due date is, if the estimated due date, or if there is a date, kind of a date of confinement. Identify potential complications prior to the delivery. So has she had any issues? Is she experiencing gestational diabetes? Is she having that hypertension? Does she have that preeclampsia? So what other complications is she potentially having during this pregnancy? Ask the patient whether she is experiencing any complications from any other of her previous pregnancies. So that would be good to know, because some of those can kind of give you a good clue of potential complications that she might currently be experiencing or have the potential to experience. Let's see here. So, just making sure, going over my notes here. Yep. Oh, the other thing is like contractions. How is she currently having contractions? Is she in that state of contractions? How many contractions is she having? The time frame in between those contractions. How long are those contractions actually lasting? So those are some other good questions to ask that we normally wouldn't be asking any other normal patient. Consider delivering a newborn at the scene when delivery is expected within a few minutes. So they're at that point. You have possibly a breech presentation. You have some crowning going on. I mean, breech is going to be something. Obviously, some other considerations, prolapse, things like that. We're gonna get into that here later. But if you have crowning, say the head is crowning, that delivery is expected probably within a few minutes. So be ready. Some type of catastrophe makes it impossible to reach the hospital. So again, if it's maybe if it's roadways, we had that missile crisis the other night, and it has the freeway shut down. That potentially could delay your transport. Or if there's no transportation readily available. So say you're on a QRU and you're still waiting for the ambulance to come out of Worley, or say from Athol, because the world is falling apart and all the ambulances are tied up. So you might have to, on that QRU, you might be the one that actually is going to end up having to do that delivery there on scene. So again, look for crowning. Ask the following question: how many weeks pregnant? Is this your first baby? Are you having contractions? The time frame between contractions. How long the contractions lasting? Do you have that urge to push? Do you have that urge to have a bowel movement, which can be a sign of they're getting ready to start pushing. Have you had any spotting or bleeding? If so, what color was it and how much? You know, has your water broke? These are some good questions to find out to help you figure out if this birth is imminent. Let's see. Do you have a rush of fluid from the vagina? So with this, we want to try not to allow the woman to get up and go to the bathroom. Reassure her that the sensation of needing to have a bowel movement is normal and means that she is about to deliver. So it would be bad that she has this feeling. She's never had a pregnancy before and she doesn't understand this. We don't educate them on scene. She goes to the bathroom because she feels like she has to poop, so she goes to the bathroom and she drops the kid off the pool, basically, right? So she delivers the child into the toilet. That would be a bad thing. All right. Secondary assessment is important. So include a complete set of vital signs, pulse, respiration, skin color, temperature, everything that we normally would do with a patient assessment. We need to do for this mother. And you need to make sure that you're very accurate on, say, the respirations and, you know, if you do a manual pressure and pulse. These are some things that we need to do and possibly every 5 minutes, depending on our time frame with this patient. If we have to stay on scene for a while or even during transport, it'd be good to get this stuff probably every 5 minutes so that we can get a good set of trending vital signs, see what's going on. Try to obtain some fetal heart tones. Utilize your stethoscope and auscultate for fetal heart tones. In full-term delivery usually occurs when the contractions are 1 to 2 minutes apart and that they last from 30 to 60 seconds. So this will come up again. I think we're going to talk about Braxton Hicks here shortly as well, so, which is a little bit. Oh, yeah, Braxton Hicks. There we go. Braxton Hicks contractions are intermittent uterine contractions that may occur every 10 to 20 minutes. So they're kind of intermittent. That is not a true sign of imminent birth, but it is a sign that maybe they need to be transported to the ED to be reevaluated. Your physical examination should focus on contractions and possible delivery. You want to try to protect the woman's privacy during the physical examination. You know, some people are going to be a little apprehensive about letting just an EMT get down there and do a physical or a visual assessment. So just try to communicate properly. Try to respect her wishes. You know, figure a way. It is important that sometime at some instances, based off of our examination, are say mechanism of injury or some of your other physical findings, your vital signs, their chief complaints. Explain to them how important it would be for you to just look to make sure that there is not a presentation down there, say of a prolapse cord, or you don't want to scare them by giving them examples, but hey, I need to take a look to see if there's any crowning, and just to double check the presentation. Reassessment, again, repeat your primary survey, focus on ABCs, any vaginal bleeding, recheck interventions if you're giving fluids. Again, you know, maybe 250 to 500 cc's boluses. Recheck lung sounds with those after each bolus. Recheck your blood pressure, make sure it's appropriate. If your assessment determines that the bleeding is imminent, notify the staff at the receiving hospital. I feel like we're really good about that, and the way things are set up now, depending on where they're at in their pregnancy, The last two, like had two close ones, actually within 30 days of each other, so within a month. And we bypassed the ED, which I'm sure some of you experienced. Bypassed the ED and actually went to the north side of Kootenai to go straight into labor and delivery. So provide an update on the status of the woman and newborn after delivery. So if you do deliver in the field, whether it's on scene or in the ambulance during transport, it is important to, if you've already talked to the hospital, update them, hey, we are now transporting to, and give them an update on the baby's presentation and the mother's presentation. And then obviously we want to thoroughly document everything that is essential for this call. Any questions out there? Because online, you guys are the only ones here. Perfect. I figured not, since nobody's typing anything. All right. I'm going to take a break and be right back. All right. Obviously on the recording, it doesn't really correlate with a 5-minute break, but sure. All right, we're going to continue and get into assessment and management of non-delivery emergencies. All right, so spontaneous abortion can occur. And it's characterized by vaginal bleeding, abdominal cramping during first half of pregnancy. In the second half of the pregnancy, the patient may present with severe abdominal pain caused by strong uterine contractions, substantial vaginal bleeding, and or cervical dilation. There's really no specific treatment for this, except we need to just do that care to the patient as far as giving high flow oxygen. We want to do a large bore IV of fluids, reassess lung sounds when you're giving those fluids, reassess vital signs, obviously. And you're going to continue with giving supportive care, supportive emotional care without giving, obviously, her false hope. And you're going to be trying just to keep her calm. There we go. Trying to switch mics. Third trimester bleeding is determined as much as possible about the nature of the bleeding. When did it start? What was was there any trauma related to this? What activity was the woman engaged in at the onset? How much blood has been lost? You know, blood loss is kind of a difficult thing for a lot of people to really figure out. You know, we go on nosebleeds and rectal bleeds, and they're like, oh, it's a lot of blood, and sometimes it looks like it's a lot of blood, and it really isn't. But we need to do the best we can at trying to determine how much has actually been lost. Is the patient experiencing abdominal pain? If so, what is the nature of the pain? What does it feel like? So making sure you do your OPQRST for that to really get a good idea of where it's at. Is it radiating, the severity, the scale of 1 to 10? Is there anything that makes it worse, makes it better? So again, that's that OPQRST. You really need to identify any changes with orthostatic vital signs as well. So was this patient laying down, you did vitals, or sitting up? Now you need to maybe consider doing orthostatic and get him to the sitting up from laying down and then up to the standing position. Obviously with help and other providers there to make sure that that patient doesn't fall should they become dizzy or lightheaded. You need to try to let's see. No, let's see. So regardless of the source of the hemorrhage, pre-hospital management is the same for this. So Ectopic pregnancy, patient is in severe pain, possibly in hypovolemic shock. So treat and focus on the ABCs. Again, supplemental oxygen and fluids for that hypovolemia and treating of that shock. Preeclampsia is going to be characterized by headache, anxiety. They might have swelling in their hands, face, and feet, and/or feet. They're possibly going to have nausea and/or vomiting. Severe preeclampsia, you may also have that pulmonary edema. So they might have shortness of breath. When you listen to lung sounds, you might have audible, like some type of fluid in the lungs. They might have some confusion or other altered level of consciousness. They could be having those visual disturbances, upper abdominal pain, myoclonus. And treatment, again, with this is going to be supporting ABCs and trying to keep that patient calm. Try to use that sweet, calm voice to just talk to the patient. Reassure them that they're going to be okay and that you're going to get them taken care of, get them to the hospital. Supine hypotension syndrome is most easily treated by placing that woman onto her left side. We've talked about that. If they possibly have to be on their back for whatever reason, again, putting those blankets or a pillow, trying to elevate the pelvis up about 6 inches, trying to just rotate that midsection over, trying to relieve the pressure that's causing that hypotension. If the patient must be immobilized, like I said, using more blankets under that right side of the board. Gestational diabetes, we're going to be doing pre-hospital management, including with high flow oxygen, IV fluids, and possibly administering dextrose as indicated. So this is maybe something we don't necessarily need to give them D50, maybe going with D5 or maybe making a D10 solution. But we obviously need to follow our protocols for that treatment. The different stages of labor will kind of, you need to understand the different stages so that you can understand what you might be expecting, or even how you can better educate that patient should they, say, be in denial or not even realize that they are pregnant. So onset of labor starts with contractions of the uterus. Lightening refers to the movement of the baby moving down into, or lightening, not lightning. Lightening refers to the movement of baby down into the pelvis prior to birth. Stages of labor first begin with the onset of the contractions and ends when the cervix is fully effaced and dilated. From the point of full cervical effacement and dilation until the fetus is delivered, and begins with the delivery of the newborn and ends with the delivery of the placenta. Preparing for delivery is important. Again, making sure that you have all your equipment readily available. You're not scrambling to get it because it's like, oh no, just tell her don't push. We're going to get you to the hospital as quick as possible. I do not want to deliver this in the field. I'm scared. You know, you can't be that way. You've got to make sure that you prepare everything. It's just like getting everything out and preparing for an intubation. Say if you see a medic or help out a medic getting prepared for intubation, you're going to get they're going to get all their stuff out, and they're going to have a plan of A, B, and C, and possibly D as far as should things get worse. With delivery, it's going to be the same idea. We're going to get, say, the OB kit out, possibly get multiple OB kits out. Again, remember, make sure that you find out, is this only the one pregnancy, one delivery? They only have one fetus, or is it multiple fetuses? Are they having twins or triplets? If maybe you don't have enough supplies you only have the one OB kit. So get other stuff out of the cabinets to help prepare you for what possibly is going to happen. Never attempt to hold the pregnant woman's legs together. Don't try to close them together or encourage her to just keep them together to try to prevent that baby from being born. Your part is to actually help guide and support that newborn as it is born. So again, the mother is going to be doing most of the work, okay? It's natural. It is just built in. Things are going to happen whether you want it to or not. So if delivery must occur during transport, stop the vehicle, have your partner or partners assisting with the delivery get out and get into the back of the ambulance with you to help. It is possible that you might need multiple sets of hands in order to make this a smooth transition. It is possible that with this you may need to call QRU to rendezvous with you or come and help you out when you pull over. So that's kind of an example of an OB kit. If you've never looked through one of our OB kits, you probably should at least get familiar. There should be a list of what's in there. At least pull up the pictures instead of opening one up, because we want to keep it as sterile as possible. At least try to pull up some pictures to make sure that you understand what each part of that OB kit is and how it is going to be used. So with positioning of the patient, you need to limit the patient's exposure and preserve her modesty, as obviously, instead of just flipping things up. You know, take into consideration, if you are in the back of the ambulance, during the day, people outside of the ambulance really can't see in. But at nighttime, it is not the case. Lights are on and people can see through the windows at night. So try to make sure that you keep that patient as modest as possible. Move the patient to the floor or other sturdy flat surface if you're in the residence. Put a pillow or blankets beneath her hips to elevate them approximately 2 to 4 inches. Help her to move into a semi-Fowler position. Okay, so she's going to be kind of laid back. I believe that Fowler position is like 30, what is it? Like 15 to 45 degree angle, something like that. So there is an angle that truly classifies as semi-Fowler. Let's see, where else are we? Yep. All right. Preparing for delivery in the field. Place towels or sheets on the floor around the delivery area, because again, this is going to be messy. It's potentially going to be messy, especially if her water hasn't broke yet. Sometimes they don't break until the baby is getting ready to push out. So be ready. You, as far as your PPE, make sure that you have your goggles. You're going to have your gown on. I would highly suggest putting on a gown of the gown to help protect yourself. Gloves, maybe a splash mask would be good. Use sterile sheets, towels from the OB kit to make sterile delivery in the field. You want to try to make sure that it says wash your hands thoroughly with iodine or scrub solution. We don't necessarily have readily that accessible. We're going to be wearing gloves. Delivering the newborn, your partner should be at the patient's head to comfort, soothe, and reassure her during the delivery. Good luck being in that position should the father be there. And we had one where he was determined to be in the back of the ambulance if we were delivering, which could can make things worse as far as his anxiety. We did have one. His anxiety level was at about an 8, and I needed him at about a 3. And we ended up having him in the front seat because we had a couple different providers in the back. Again, want to make sure we have a couple of competent hands back there. And he was in the front seat during the transport. I don't remember who was driving, but he was all amped up because he wanted to be in the back, and he did not want that baby being born unless he was there ready to. I mean, he wanted to be all in. He was all in. So good for him for that. But just make sure that you try to be aware of that, and yeah, just be aware and do the best you can. Continually assess the patient for crowning. Again, you're going to have to look to assess that for crowning. Do not allow an abrupt delivery to occur, because that can cause damage to the mother and or to the fetus. Can actually hurt them. You want to position yourself so that you can see the perineal area all the time. Between contractions, you want to encourage the patient to rest. Try to focus on just breathing, getting that kind of just controlling herself, maybe even giving her supplemental oxygen, because during contractions and pushing, she's not going to be breathing, and she's just going to be kind of grunting as she tries to push out. So possibly give her some supplemental oxygen. When the baby is born, you want to wrap that newborn so that only the face is exposed, because we want to try to keep that baby as warm as possible, trying to maintain that baby's heat. After suctioning, keep the newborn at the same level as the woman's vagina until the umbilical cord is cut, because that baby is still receiving nutrients through that umbilical cord. Here's another area that I struggle with, and I'm sure I'm not the only one, but this is an area that I struggle with, the APGAR score. It's useful means of evaluating the adequacy of a newborn's vital functions immediately after birth. There's 5 parameters: heart, respiratory, muscle tone, reflex irritability, and color. And everything is scored from 0 to 2. Each one of those, so all 5 of those, 0 to 2, 1 minute, and again at 5 minutes after birth. So that's important to understand. So at 1 minute and then at 5 minutes. Most newborns are vigorous and have a total score of 7 to 10. A score in the range of 4 to 6 will require resuscitation. Cutting the umbilical cord, making sure that clamping of the cord should be delayed 30 seconds after delivery unless the newborn requires resuscitation. After the cord has stopped pulsating, you want to tie or clamp the cord approximately 4 inches from the newborn's navel. And then place the second tie 2 inches from the first one. So 4 inches from the baby's navel, and then an additional one 2 inches beyond that. And then you want to cut in between those 2 ties. And if you've never cut one, it is a tough little sucker to cut. It is very fibrous, and it is not like it is just a piece of paper that is a simple snip. It is an action of actually, truly trying to cut through that cord. It's a tough little guy. And then you want to wrap the newborn in a dry blanket. Wrap them up. Keep them warm. Once that's done, you also want to reassess the woman and prepare for delivery of the placenta. Delivery of the placenta usually is within a few minutes of the birth, although it can take as long as 30 minutes. You want to pull on the umbilical cord and trying to speed up the delivery of the placenta. You want to wrap the entire placenta and umbilical cord in a towel and place them in a plastic bag. This is where it's a weird area, and again, you want to try to respect people's wishes, because some people, they want to keep that placenta for different things. So it's just, again, try to be respectful and then abide by their wishes. Postpartum care, you want to place a sterile pad or sanitary napkin over the vagina and straighten the woman's legs. Okay, so we never obviously want to pack anything. You're just trying to cover and keep it sterile. Slow postpartum bleeding by gently massaging the fundus with a firm circular kneading motion. So again, that's going to be kind of massaging the abdomen in a circular motion, trying to like knead it, trying to help it with its normal function of trying to basically slow itself down from bleeding. We used to use oxytocin in the field, and obviously it'd be more of a longer duration of, say, transport, a longer term of bleeding when this doesn't necessarily work. We want to make sure that we record the time of bleeding. We need to record the time of birth. It's important for that, especially for your, not only for your patient care report, but for the hospital and the mother itself. For the mother. Delivery of the newborn. After delivery, you need to obviously get the woman's vital signs as well. So don't forget, once you have the baby in hand, don't forget about the mother. Monitor the woman's condition closely for postpartum hemorrhage and shock, seizure activity, or even respiratory difficulty. So we want to manage those appropriately when we see those happen. Postpartum hemorrhage is a loss of blood that exceeds 1 pint during that first 24 hours of giving birth. Emergency situations is placenta is not delivered within 30 minutes. Other emergency situations when more than 500 milliliters of bleeding occurs before delivery of the placenta, or substantial bleeding occurs after the placenta is delivered. So any of these, obviously, we're wanting to provide rapid transport. Get them to the hospital as quickly as possible. Place a sterile pad or a sanitary napkin again over the vagina to collect any blood and manage external bleeding from perineal tears with firm pressure. So should that perineal area tear, maybe it was they did push rapidly and there was an explosion of the baby coming out, and that could cause a tear. Or they tear naturally during birth. It's important to make sure that some care is given to that. Definitive treatments for many of abnormal labor and delivery problems is a cesarean. This is a lot of times this is going to be an emergency situation where it's requiring basically them to open up the mother and remove the baby because they cannot be delivered through the birthing canal. It's rapid transport is very important. Obviously, we need to get there safely, but rapid transport to the hospital is crucial. Preterm labor is labor that begins after the 20th week of gestation, but before the 37th week. Okay, so that's preterm. In the field, the best treatment option is going to be a bolus of fluid solution. The newborn that delivers before the 36 weeks of gestation or weighs less than 5 pounds at birth is considered a preemie, so that premature. So there's a good picture there to kind of illustrate that. So understanding what the term for preemie is, again, delivery before 36 weeks or a weight less than 5 pounds. They're smaller and thinner than a full-term newborn. The vernix caseosa, it will be missing, so that's that waxy, white waxy substance on their skin will be missing in that preemie. And administering supplemental oxygen through a tent above the newborn's head might be necessary. Let's see. Double check notes here. All right. Fetal distress is a condition that may cause hypoxia in the baby. It could be as a result of hypoxia, so the baby's not getting enough oxygen. The nuchal cord, which is going to be that wrapped cord around their neck, could cause fetal distress. Obviously, it's straining on that baby's neck, and then it's also stretching out of that cord. Any trauma, abrupto placenta, fetal development disabilities, and or a prolapsed cord can all cause fetal distress. We want to obviously rely on the information provided by the woman on fetus movement. Can they feel the baby moving? When was the last time they felt the baby moving? That's another good question to ask. And then provide support to the woman with rapid transport. As well, obviously trying to keep the woman as calm as possible, trying to reassure her emotionally. Uterine rupture puts women at risk. The ones that are at greatest risk are women who have had several children and those with a scar on their uterus. Long, painful contractions, but then the contractions severe abdominal pain. So it's going to be a significant difference. So the contractions are more of a cramping, and now afterwards she'll have abdominal pain. So it's good, again, part of that assessment, identifying what the quality of that pain is, and trying to identify the difference between the contractions and that abdominal pain. Substantial vaginal bleeding may or may not be obvious. Some high-risk conditions to be aware of are going to be meconium staining is one. In cases of fetal distress, the fetus may actually expel meconium into the amniotic fluid, and this may result in chemical pneumonia in the newborn. You're going to have a yellow tint in the amniotic fluid, suggesting that meconium has been in the amniotic sac. Let's see, did I say that right? Fluid, yeah, for a while. So if it's yellow, if the amniotic fluid is yellow tinted, that kind of tells you that meconium has been in there for a while. Green, black color, especially with the presence of particulate matter, so you're going to see that, and it's going to be obvious, indicates that it's a recent passage of meconium and is a sign of danger. So we want to try to get that necessary. Be vigilant regarding the need for suctioning. So you got to really be with that. And then call early for paramedic backup if you don't already have one on scene. Because this is one where we might actually do suctioning down into the lungs as well. Equipment, but like with us, I think locally we have only the one OB kit on the ambulance, and then there's going to be hopefully another in the QRU. Consider the possibility of twins, which is why you need to probably have you're assessing. You find out how many are they having. Do they know that if they're having twins? Grab that other OB kit. So you want to obviously consider the possibility of twins if the uterus is still large and firm after delivery of the first newborn. If there is more than one fetus, so you need to repeat the early on and prepare for that delivery. When the first newborn is born, you want to clamp and cut the cord approximately 30 seconds following the birth. So try not to delay in this. And before the second newborn is delivered. Pay meticulous attention to keeping the newborns warm, well oxygenated, and in as sterile an environment as possible. again, make sure you have enough hands in the back of the ambulance if you are transporting and you have a long distance transport, or there is a chance of delivery en route to the hospital. So make sure you have plenty of hands to help with that. Make sure you identify the newborn delivered first as baby A by loosely tying an extra length of tape around the foot. There's a good way. And then record the time of birth of each twin separately. So again, making sure that each one has its own time of delivery. Cephalopelvic disproportion is when the head of the fetus is larger than the pelvis. With this is an emergency because the baby cannot be delivered naturally through the birthing canal. A cesarean is required to get this baby out. This is going to be an imminent danger to the baby because as the mother tries to push, the baby is going to start going into distress, and obviously that would be bad for the baby. It may cause massive hemorrhage along with postpartum complications. Intrauterine fetal death is a complication of labor and delivery that can result in death of the fetus. Grieving parents will require all your professionalism, obviously, and support skills. This is one where it'd be good to find out, if they have a religious preference, if they have, in this case of a fetal death on scene, if there's some type of a religious person that they would like us to contact, any additional family to support them or friends, or if they have no other support, maybe getting our chaplain involved to help provide them some type of emotional support. You do not want to attempt to resuscitate an obviously dead newborn. It's going to be confusing to the parents, and you do not want to confuse such a newborn with newborns who have had a cardiopulmonary arrest as complication of a birthing process. Amniotic fluid embolism is a life-threatening condition that is extremely rare. Hardly ever seen in the hospital setting. Some of the factors include maternal age greater than 35, eclampsia, abruptio placenta, placenta previa, urine rupture, and or fetal distress are some of the factors that could cause this. Or not cause it, but are some of your risk factors, sorry. Amniotic fluid and fetal cells enter the woman's pulmonary and circulatory system through the placenta via the umbilical vein. Some of the signs and symptoms include a sudden onset of respiratory distress and hypotension. So treatment should be focused on supporting the woman's vital signs. Again, supplemental oxygen, keeping them warm, and providing IV support. Other complications of delivery could be a breech presentation. Different types of breeches can be flank, incomplete, or complete. So with frank presentation. Frank presentation is hips flexed and knees extended with buttocks presenting. So butts coming out first. Incomplete is when one or both hips and knees extend with one or both feet presenting. And a complete is when hips and knees both flex with buttocks presenting. Newborn is at greatest risk for delivery trauma, and make sure you have medical control to help guide you. So make sure they're on the phone or contact them via radio. Limb presentation, newborn must be delivered surgically in the hospital. So here's the limb presentation, like a leg, could be a leg or an arm presenting And when this happens, you want to try to keep that limb as sterile as possible by covering it with a sterile dressing. Place the patient on her back. When you come across these presentations, you want to place her on her back with her head down and her hips elevated. So laying her down, trying to elevate those hips. You can put padding underneath, trying to keep those hips elevated. You want to prevent further trauma to the newborn that could result from the patient's continued pushing. So you want to try to encourage the patient, the woman, not to push. Okay, trying to tell her, the best you can, tell her not to push. Obviously, transport rapidly and safely to the hospital. Make sure you notify the hospital early on of the presentation, what you see, so that they can also prepare for cesarean. Shoulder dystocia is when a woman with diabetes, large fetuses, and fetuses that are post-term are at risk for this complication. Occurs after the head has been delivered and the shoulders cannot get past the woman's symphysis pubis. The major concern for the newborn is damage to the brachial nerve plexus. That's the biggest concern for the baby. So different maneuvers may be attempted to widen the woman's pelvis or reposition the fetus. The book talks about the McRoberts maneuver, and it's one of the safest. And some of the key points of that McRoberts maneuver is it doesn't change the actual dimension of the maternal pelvis, but it actually relieves the shoulder dystocia by way of marked cephalad rotation of the symphysis pubis and by flattening the sacrum. The use of this maneuver alone has been found that it alleviates 39 to 42% of shoulder dystocias. But obviously, with this prolonged application of the maneuver may unduly stretch that fibrocartilaginous articular surface of the symphysis pubis. Big words there. Nuchal cord is when the umbilical cord may potentially become wrapped around the newborn's neck. This is obviously a complication and very dangerous for the baby. The nuchal cord that is wound tightly around the neck could cause the newborn to asphyxiate. So with this, we want to make sure that we try to slip our finger under the cord and gently attempt to slip it over the newborn's shoulder and head if we can. If unsuccessful, though, cut the cord before delivery can continue. Obviously, if this is something that if you don't have time to get the patient and this baby to the hospital. If the cord is wrapped more than once around the neck, must clamp and cut only once. Just make sure, clamp once, cut once. And then unwrap it from around the neck. There we go. Prolapsed umbilical cord. So when you have a presentation of the cord, it's important to understand and identify the prolapsed cord versus a limb presentation. So make sure when you're looking, you're not mixing up the two. The cord is when the cord emerges from the uterus ahead of the newborn. The blood supply with this, why this is dangerous is the blood supply to the newborn may be interrupted. So as this baby is in there, its nutrients, its blood supply could be interrupted, and then it will obviously put that newborn into distress. You want to prevent the woman from pushing when you have a prolapsed cord, preventing them from pushing and compressing the umbilical cord as they push. Try to prevent them from doing that. You want to try to get them on their knees and elbows, like in the picture here, and get them with their basically head down, butt up position, and continue to encourage them not to push. So you're just talking to them and providing that emotional support not to push. Uterine inversion is when the placenta fails to detach properly and adheres to the uterine wall when it is expelled. So it can result from placing excessive pressure on the uterus during fundal massage or from exerting excess traction on that umbilical cord. Make an attempt with this. You need to make an attempt to replace by using the palm of the hand to push it back inside the body, according to what the book says. Never use your fingers with this. Try to, when you're trying to replace a prolapsed uterus, again, using the palm of your hand and provide pressure, trying to push it back in. You want to administer 100% oxygen to the patient. Obviously, again, getting IV started, large bore, providing fluid support, and then continuing to treat signs of shock. Obviously, you'd have to monitor the patient's vital signs regularly, and that's probably, again, an every 5-minute deal where we're reassessing vital signs. Pulmonary embolism may form from several sources. It's a blood clot arising in the pelvic circulation is a frequent cause of this. You want to suspect an embolism when they have a sudden breathing difficulty, they have elevated heart rates, hypotension in the postpartum state. And you, again, with this, we're going to be managing the same way in any other PE by providing them oxygen support and IV support and rapid transport to the hospital. Spina bifida is when a portion of the spinal cord or meninges may protrude outside of the vertebrae. So it's easily seen on newborn's back and usually occurs in lower third of the back. And it's important to cover the open area of the spinal cord with a sterile, moist dressing immediately after birth. Then obviously maintain the body temperature is important when applying that moist dressing. You have to make sure you keep that baby warm. So this is, I don't know if the book shows pictures. Obviously there's not a picture here in the PowerPoint. But here are some examples of what you would see with a spina bifida patient once they're delivered. So you could have this, this bulging in that lower 2/3 of the back. And I mean, it's going to look potentially like a large blister in some of these patients. I think there's kind of a presentation there. And here you go. Oh, let's see. So here's a presentation of a spina bifida. So again, you're going to try to keep this section of the patient covered with a sterile moist dressing, and then obviously because it's a moist dressing, we want to try to keep the rest of the patient warm. So this is what you would see upon delivery. This spina bifida is obviously is it's going to be a difficult thing for that patient. Obviously, as it's going to affect their growth, and if the mother wasn't aware of this because they hadn't gone to the doctor, hadn't done those things, this might be a very scary thing for them, as it's a little awkward to look at. So again, educating that mother of what it is going to be important, and providing emotional support. You know, this is something that actually, if it is noted early on, can actually be fixed prior to delivery. Clicker. Let's find my clicker. Okay. So those are some of the postpartum complications. Now we're going to get into neonatal resuscitation. So some of the physiology in utero fetus receives oxygen from the placenta. We know this. As the fetus is delivered, a rapid series of events occurs to enable that newborn to breathe, which is called a fetal transition. Following the fetal transition, the neonate breathes and oxygenates. Remember, before this, obviously, it's getting it from the placenta, and there are some changes within that baby that helps out with this fetal transition. So here is kind of an example of that. The workup of the umbilical cord as here. So this is the placenta, the umbilical cord, the umbilical vein, the navel. So this is where it actually enters into the baby. And then the workup of nutrients and blood, oxygen, all that, and how it is piped, because it is piped a little bit differently here through the heart. And then in that fetal transition, things close off. You got the ligament arteriosum here, where over here it's the arterial duct. So this closes off. And then also right in here, right here is the fossa ovalis, and that closes. And with some patients, this doesn't close off completely. And this is possibly something that could give them some type of complications after delivery, and potentially they could have surgery to kind of fix this. Some of the causes of delayed transition is going to be hypoxia, meconium staining, or blood aspiration, acidosis, hypothermia, pneumonia, hypotension, sepsis, birth asphyxia, pulmonary hypoplasia, which is underdevelopment. It's underdeveloped, and respiratory distress syndrome. So if the fetal distress occurs in utero, the problem is usually caused by compressed blood flow in the placenta or the umbilical cord. After delivery, usually the result of an airway or breathing problem. Some of the clinical findings are going to be persistent cyanosis and or bradycardia. You're going to have hypotension of the baby, respiratory depression or apnea caused by insufficient oxygen delivery to the brain. Or you could have poor muscle tone from hypoxia and that hypercapnia, so that low oxygen and increased carbon dioxide. Neonatal assessment and initial steps are aimed at stimulating the newborn to begin spontaneous and effective breathing. It's going to consist of drying that patient, keeping them warm, positioning that patient, maybe providing some type of suctioning to help clear out the airway, and then stimulating that neonate. You want to initially do a rapid assessment of the newborn. May be done simultaneously with treatment interventions, obviously. And then obviously we want to note the time of delivery and then monitor ABCs. Assessing the skin color in newborns has several unique features. A newborn who has not begun to breathe air will appear cyanotic, so it's going to be pretty obvious. Many newborns become centrally pink but have blue hands and feet, so don't get overly worked up about this. If the newborn has a normal breathing pattern and pulse greater than 100 beats a minute but maintains central cyanosis, so that's that bluing of the trunk, or the mucous membranes provide supplemental free flow oxygen. So we're just going to make sure, again, this is part of the equipment that we need to make sure that we have readily available, is that BVM already plugged into oxygen, ready to provide this treatment should we need it. Some of the first steps in caring for that newborn is to provide warmth. You want to keep that baby warm. You want to clear the airway. If necessary, we have that bulb syringe, the bulbous, to help suction. And remember, when you utilize that, squeeze it before you put the tip into, say, the nose, and then apply it to the nose and then release. Okay, you don't want to try to blow that stuff down into the airway further. You want to dry and stimulate the newborn. Position the newborn on a flat surface and ensure an open airway. Additional tactile stimulation may be provided briefly to stimulate breathing. They don't like being rubbed on the back, so turning them over and kind of rubbing the back is going to stimulate them, or tapping on the feet is going to stimulate them. So those are some of the different ways. Let's see. I guess in your book there's a table 35-4 shows the app score table. Again, that's going to be important to understand. Maybe even have that readily available as you're getting ready to deliver this baby. Have somebody readily available, making sure you familiarize yourself on the way to the call of what the APGAR is supposed to look like, so that you're ready for that as well. There we go. Mike is back. Mike. So, yeah, I'm sorry if you didn't hear it. So, table 35-4 shows the APGAR score. Make sure you understand that. Go over that. Familiarize yourself on the way to the call. If you know you're going to a delivery or a potential delivery, make sure you visit that on the way to the call, as well as some of the protocols to reassure yourself you know what you're doing. Because you do. It's just, when things get a little crazy, it's good to have that reassurance. So there's an algorithm for neonatal resuscitation consisting of the initial steps in stabilization, providing supplemental oxygen with a bag valve mask, monitoring that oxygen. If compression or if the heartbeat is less than 60, we want to start compressions. Consider intubating and continue chest compressions and coordinate with positive pressure ventilation. So the need for resuscitation is based on 3 key parameters: respiratory effort, heart rate, and the color of the baby. So if the heart rate remains below 60 and we want to administer IV epinephrine, consider hypovolemia or pneumothorax. And this is a good time to make sure that the Broslow tape is out. Revisit if you're using hand-heavy, make sure that is readily available, and make sure all your equipment's readily available. Understand our protocols, have somebody pull up the protocol list to make sure that we're doing our checks and balances as well. Free flow oxygen. If the newborn is cyanotic or pale, provide that oxygen. If we're going to use this if positive pressure is not indicated. And make sure that the oxygen flow rate should be set at 5 liters a minute. Okay. Bag valve ventilation indications are apnea, inadequate respiratory effort, pulse rate less than 100. And obviously some of the respiratory signs are going to be periodic breathing, that irregular respirations, intercostal retractions, that nasal flaring and grunting on expiration. So We want to make sure that we have that infant size or that neonate size for the mask to make sure that we're utilizing that with the bag valve mask. Understand that those lungs are so tiny that we don't need to give a full compression of that bag in order to give them oxygen. We want to be very cautious because we don't want to damage those lungs, right? We don't want to pop them like a balloon. We just want to try to get some chest rise. That's all we're looking for when we're giving positive pressure ventilation. And then with that, obviously making sure that we have breath sounds. It's going to be very difficult if you're using that double diaphragm stethoscope. Make sure you have the proper side. Use that smaller side to listen to those lung sounds. And with this, you might need to listen at least left and right and not necessarily on the top, because you just might, it's going to be difficult to figure out if you're hearing both sides at the same time. You put it on the front of the chest, you might actually hear both lungs, and it's going to be possibly could be difficult to differentiate if it is truly the left or the right, unless you go to the sides. Hopefully that makes sense. Circulation, chest compressions. Here's a couple examples. Obviously, we know this. The provider, you have one person providing supplemental oxygen with the BVM, and the second provider is going to be wrapping that chest and using the thumbs into the center of the chest, getting that full squeeze. The single provider is going to be trying to position again, making sure that the shoulders are padded underneath, that the airway is open, and you're providing that chest compressions as shown there with just a couple fingers. Placed between the xiphoid and the imaginary line between the nipples. Okay? You want to make sure that we're in the proper location so we don't cause any unnecessary damage. Bag valve mask is going to be performed during a pause after every third compression. So 3 compressions, bag. 3 compressions, bag. Keep in mind that adequate ventilation is absolutely critical to the successful resuscitation of that neonate. Consider vascular access. We're looking at IV. You're looking at the peripheral veins in the AC and or the saphenous veins just anterior to the medial malleolus of the ankle. So that'd be that lower picture there. Or use an IO access through the proximal tibia, as with older children. Though rarely performed at the advanced EMT level, you may also carry umbilical vein catheters in your local protocols if your local protocols allow umbilical vein catheterization. Cool. Any other questions or any questions on these neonate post-delivery, neonate resuscitation, postpartum complications? Anybody? There's nobody here, so all right. Well, I don't feel like I need to take a break at the moment, so we're just going to continue on, try to finish this out. Just double check. Actually, so we're almost done, which is good, right? It's good. So, pathophysiology assessment and management of specific conditions. Apnea is common in newborns delivered before the 32 weeks of gestation. And if this occurs, we need to try to respond by stimulating and then provide, if there's no response to stimulation, because they should breathe on their own, right? But if there's no, we want to stimulate them if they don't. Again, we can rub the back, flick the bottom of the feet as far as the stimulation. If there is no breathing from the stimulation, then we need to provide supplemental oxygen And if we don't, obviously it can result in hypoxia and bradycardia. Remember that obviously with pediatrics, neonates, they don't just go into cardiac arrest. Typically, when they do, it's typically because of respiratory failure. Often follows a period of hypoxia or hypothermia. Other causes include maternal or infant narcotic exposure. So these are that apnea causes. So airway and respiratory muscle weakness, septicemia, prolonged or difficult labor and delivery. You got gastroesophageal reflux, so GERD, and central nervous system abnormalities could all cause that apnea. A newborn with apnea needs respiratory support, obviously, to minimize that hypoxic brain injury or other organ damage. It's good to understand the difference between primary apnea and secondary apnea. Newborn has experienced a relatively short period of hypoxia. The use of dry and stimulating may cause the resumption of breathing. So if hypoxia continues during primary apnea, the newborn will gasp and enter secondary apnea. So then the positive pressure ventilation by the mask, the bag valve mask, is required. So primary apnea will reestablish a breathing pattern, but will be irregular and possibly ineffective. Secondary apnea will not resume breathing of his or her own accord. So those understand the differences between that primary and secondary apnea. Bradycardia is the most frequently a result of inadequate ventilation and often responds very effectively to oxygenation of that baby. So positive pressure ventilations, if we give them that supplemental oxygen. You obviously want to assess the patency of the airway. Begin chest compressions if that heart rate is less than 60 beats per minute, despite at least 30 seconds of effective ventilation. So for persistent bradycardia, we want to make sure that obviously, and we have that pretty readily available in our system here, but a paramedic, make sure a paramedic is either en route or called for so that there can be an administration of epinephrine for this patient. Hypoglycemia. For this patient, we need to understand that hypoglycemia is considered blood sugar less than 45, okay, less than 45. Most newborns remain asymptomatic until their sugar levels decrease less than 20 for a substantial length of time. We want to try to treat them accordingly and make sure that you're doing a good assessment. Some of the symptoms can be quite nonspecific, as it says. May include cyanosis, apnea, irritability, poor sucking or feeding, some limpness or floppiness, so hypotonia, irregular respirations, eye rolling, hypothermia, and decreased response to stimuli. With this, we want to obviously make sure we follow our protocols as far as administering fluids. Let's see. The book talks about administering 10 milliliters per kilogram of isotonic crystalloid over 5 to 10 minutes. So typically with pediatrics, we're doing that bolus that we have that 10 milliliter per kilogram. So the book talking about with this patient, consider administering 10 milliliters per kilogram of an isotonic crystalloid over 5 to 10 minutes. Okay, with that, you need to reassess blood sugar levels in all sick newborns and evaluate the newborn's vital signs. continually evaluate their vital signs. After you establish good oxygenation, ventilation, and circulation, manage the hypoglycemia. You want to give them warm IV fluids, which can assist in rewarming that patient because, of course, you've already got them wrapped up, but you want to try to prevent hypothermia. Hypovolemia is going to be when the newborn, in that hypovolemia in the newborn is, shock will appear pale and have weak pulses. They could have either tachycardia or bradycardia, and that's going to be persistent tachycardia, so persistent rapid heart or a persistent low heart. I'm sorry, back on that 10 milliliters per kilogram, that was for hypovolemia. That wasn't for hypoglycemia. Sorry. So yes, so with this patient, this is where we're administering that 10 milliliters per kilogram of fluids over 5 to 10 minutes. So yeah. Sorry, I messed up. Any questions? Because that is all she wrote. If you're online, make sure, and you have somebody that is sitting with you, make sure you type their name in the chat so that they can get credit for this. Otherwise, they're not. Thanks for attending. If you guys don't have any questions, I will see you next week or on shift.